and welcome to part 2 of oxygenation and perfusion. We're picking up after we've looked at the pathophysiology of respiratory and cardiopulmonary functioning. So now we want to look at how to apply that information when it comes to patient care. The first thing we want to do, obviously, is get some history on that client and then do some physical assessment. So when it comes to getting a nursing history, we want to look at their history of respiratory infections. What kind of infections have they had? Are they prone to asthma? Are they prone to getting bronchitis every winter? What puts them at risk? What about allergens, allergies? This isn't necessarily specific to medications, but things that they're allergic to in the environment. Maybe dust. We're around a lot of pollen, seasonal triggers that might affect people's breathing. Health risks. This is a big category. Smoking. Are they a smoker? Are they around smokers? Smoking is the most common cause of COPD, and so knowing that is helpful. Also, maybe their nutritional status, poor nutrition, can affect their ability to get around and such. We might want to know even when was their last flu vaccine, their pneumonia vaccine, because those can be things that decrease risk if they've had those, and encouraging people to get those. When it comes to health risks, knowing that pneumonia is really critical about understanding how that falls in with the client. Pneumonia is the 8th leading cause of death in America today. And studies indicate that healthcare associated pneumonia, which is pneumonia that people got from being in the healthcare environment, it's categorized as healthcare associated, especially when they have been in the hospital and then they return to the hospital for more than within a 90-day period, and they're hospitalized for more than a couple days. And so that's considered hospital acquired. And in the event of hospital acquired, it usually is a more severe type of pneumonia than that's community acquired. But even then, community acquired pneumonias make up about 1/3 of the pneumonias that are out there. Hospital acquired are often counted in the community acquired because they're out in the community being treated and maybe not hospitalized. So it gets really tricky, but it's a really severe complication. So we want to know about that and know if they've been sick and their health risks. Peripheral vascular disease is important for understanding circulation, getting medications to the periphery and such. So if they've had atherosclerosis, a history of that, maybe venous stasis ulcers, and not necessarily deep into our semester, but talking about what happens, skin lesions that can occur because circulation has decreased, and that's important for us to know. Medications that they're on, for example, bronchodilators, anti-inflammatories, cardiac meds, over-the-counter meds, heart meds, any of those opioids that can decrease their respiratory rate are important things for us to know that exist related simply to their history. Once we know their history, then we want to get some assessments to help us better understand the client. So we want to look at their respiratory system. Listen to those lungs. Really listen to their lungs. Inspect that chest so that you can see if they're struggling for air. There's retractions, heaving as far as pulling for air, that dyspnea, difficulty breathing. You want to get good vital signs as well. That's a really good indicator as those two systems, how they're functioning. So get a good look at those, including an SpO2 value can be very helpful. We want to look at diagnostic studies. For example, arterial blood gases. Arterial blood gases are ordered by the physician. We can't just get them. And when they get arterial blood gases, it's coming directly from the artery. So the artery is our oxygenated blood. That's why it's a critical value over looking at the SpO2. The SpO2 being the pulse oxygen saturation, the hemoglobin, oxyhemoglobin that we're looking at. The values are the same, but the arterial blood gas can be more accurate because they're looking directly at the blood. What you need to know from a nursing perspective, we don't typically draw the ABGs. You have to be certified to draw those because it's a difficult stick. It's a painful stick. But we do help out in this aspect. If arterial blood gases are ordered, we need to make sure and understand if they're to be done on room air or with oxygen. If the client is on oxygen, they must be on room air for at least 30 minutes. Okay, that's really important related to getting an accurate blood glucose. What's important for us to realize is that when a client's PaO2, which is the partial pressure O2, it's the diffused available oxygen in the blood, is below 60, that's considered respiratory failure. The normal PaO2, just a reminder, we've gone over these before, I know, but the normal is 80 to 100. So peripheral artery disease can lead to decreased circulation of oxygen, and it can affect hair growth in the extremities. So we can notice some of that on the legs. Maybe there's pale pulses. The client's pale, sorry, their pulses are weak, their feet are cool, and all of those people may have some peripheral vascular disease. So that gives us an idea with these assessments. What are we looking for? Shiny legs, you might hear described for a client, and so falling into what are their blood gases? Is it supporting normal body functions? All right. Okay, oximetry. When we do pulse oximetry, we need to be sure and know what their hemoglobin is, because if you'll recall, hemoglobin is what has the oxygen, that's carrying the oxygen, and if someone's anemic, the pulse oximetry doesn't know any different than there's oxygen on the hemoglobin they have. But if the hemoglobin is low, that tells us that this might not be the best indicator of where they are as far as their available oxygen, the oxygen that's being used. So a low hemoglobin could appear to be normal because what hemoglobin there is saturated. So it's important that we get that hemoglobin level for the client. Chest x-rays, looking at those, seeing where the clients are. Again, we're not diagnostic related to the chest x-ray, but as nurses, we want to see if there's improvement with their chest x-ray and what's going on. A TB skin test is an important measure or assessment related to a client's maybe history or complication of respiratory issues. When we do a TB skin test, we're giving them the antigen, right? Antigen is coming to dinner, and so we're putting in that foreign body into them to see if there's a response. The normal amount is 0.1 milliliters, and it's given intradermal. That's what we practiced in the skills lab. We're looking for 1 centimeter of induration versus just erythema, right? Erythema being redness. Redness does not count as a reaction. There has to be a change in the texture of the skin. If a client is immunocompromised, then a reading of 0.5 centimeters is considered positive. We read the skin tests in 48 to 72 hours. When we do throat cultures, you want to make sure that they rinse their mouth with plain water just to get rid of some of the oral organisms that are in there, normal flora, as much as we can. And then you want to swab the oropharynx and the tonsillar region, trying not to get to cheeks and tongues and all of that. So swabbing towards the back. Take your culture swab, you can see the picture there a little, you might have to hold the tongue down, and you want to take the swab into the side of their mouth and then go to the back of the throat. And it does cause a little gag reflex, if they have a gag reflex, which is not particularly comfortable. Sputum specimens, this another one, rinse the mouth with water to reduce that contamination by oral microbes. Have them breathe deeply a few times and then cough deeply from their diaphragm. Not you want to cough deep so that they're hopefully producing those sputum plugs into a sterile specimen container. When we're checking for TB, they'll not only do a TB skin test, but try to get sputums for acid-fast bacilli, AFB sputums. And those are light sensitive, so they have to go into a light sensitive specimen container. If people can't cough, sometimes we have to induce cough or to suction maybe the sputum, which we practiced in the skills lab as well with our Lukens traps. The best time to get a sputum specimen, seeing if you remember from skills lab, in the morning. That's mostly what people have been laying down, things kind of pooling around, and so like cough that stuff up. You want to try to make sure that the client hasn't had any antibiotics prior to a sputum specimen, because then that antibiotic is working on that specimen. We might not get a good culture. Pulmonary volumes are measures of people's ability to take in deep breaths and to blow, and one of those measures that we do is a peak flow, which is a different measure than having someone do our incentive spirometer. So with the incentive spirometer, we're breathing in slowly to fill those alveolar sacs. But when we're doing a peak flow, what they do is they get a similar device. It's not quite the same, but it's a similar little plastic device that you put the mouthpiece to. And instead of inhaling slow, now you take a deep breath and blow hard into that mouthpiece to see how much it raises the little dial. And so that's a measurement then of the amount of air exhaled after a maximum inhale. So inhaling as much as they can and then to see. And the average for a client is around 500 to 750. So looking at that. Now, I just want to emphasize that for most people, one simple value, one assessment isn't a complete assessment or indicator of a condition. So you want to do multiple measures, multiple assessments to come up with best nursing diagnosis and best care plans. That peak flow got me. All right. Some other assessments, cardiac system, that was mostly pulmonary type assessments. The cardiac system, looking at vital signs, getting the blood pressure in both arms and comparing which arm is the highest. Best case scenario, we want to continue to take blood pressures in the highest arm. It's not always possible, especially in the hospital, but doctors' offices and clinics, this makes a lot more sense. You can imagine in the hospital, they have IVs, they've had a stroke, there are things that make taking a blood pressure in one arm contraindicated. So we just need to be careful about that, but know that both arms aren't always the same. One is typically a little bit higher. When we are taking blood pressures, another measurement that we can do is the ankle brachial index. Now, the ankle brachial index is to help diagnose, help assess the status of peripheral vascular disease. We talked about it earlier. So how do we do that? Well, we're going to average some blood pressures here. So what we're going to do is get the mean or the average of 3 systolic pressures of the lower extremity. All right, so you get that thigh cuff and you take 3 blood pressures and you average the systolic. So you get 120, 130, and 125. The average, 125. You get that. So then we're going to divide it by the average of 3 systolic pressures of the upper extremity. All right. So if the lower extremity averaged 132, and the upper extremity, after you took your 3 blood pressures, there are 3 blood pressures, averaged 124, you divide 132 by 124. to get 1.06. All right, let's just say it one more time. I know it's weird because I'm not able to point and show you blood pressure cuffs and stuff. So you take 3 blood pressures on the thigh, average the systolic. Okay, so that's the top number that we're going to divide by. You're going to take 3 blood pressures on the upper extremity, on the arm, get your brachial measures, and you're going to average those 3 systolic. Divide the thigh measure, the thigh mean, that was that 132, by the upper arm average, which was 124, to get 1.06. Okay, got it? I hope you're saying in your mind, like, so what? What does that mean? I knew you'd want to know. And here's what it goes. A measurement of the ankle brachial index, which isn't that interesting? Ankle. Well, it's not necessarily the ankle. But the ankle brachial index is needs to be greater than 1.1 to be normal. Okay, so higher than 1.1. Less than 1, so just a 1, is abnormal, with the majority of people with peripheral arterial disease having ankle brachial index ranges from 0.3 to 0.9. All right. So I think that's interesting information. Can I say honestly, I've never done this in my whole entire life as a nurse, 40 years. But I think it's fascinating that we could get an indication. So interesting if you had someone that had maybe a history of peripheral vascular disease, and you do this simple little test to see how they're measuring and how that looks. So as just a graph, a 1 to 1.29 is normal. 0.91 to 0.99 is borderline compromise. 0.41 to 0.9 is mild to moderate, and less than 0.4 is severe disease. Okay? All right, so there we go. Other diagnostic studies. Lab, a complete blood count. BMP, metabolic panel, we're going to be more interested in that when we look at fluid and electrolyte balance, but electrolytes can also give us an idea of perfusion of the kidneys. So that can be helpful. Lipid values, is their HDL high or low? Is their LDL high or low? Their total triglycerides, giving us an idea of where they are cardiovascularly. Cardiac enzymes, I'm going to stop and take just a little pause here, are indicators of heart injury, myocardial infarction. And so the CPK or the CK, depends on who you read, but the creatinine phosphokinase is a measure of heart injury or muscle injury, as well as the troponin level that's released when someone's had a myocardial infarction. It's a result of cell damage. Elevated levels of these enzymes can help differentiate between a myocardial infarction and chest pain from a different cause, maybe like angina or pleuritic pain of some sort. When someone has a CK rise of 4 to 6, CK rise 4 to 6 hours after an MI, and it peaks 18 to 24 hours post an MI. So normal is 0 to 6% for the heart, 5 to 35 micrograms per milliliter for a male. Troponin is a 0.1 to 1 nanograms per milliliter, which are released within hours, 3 hours of a heart attack, and it's more sensitive than the CPK. What I think is interesting about the CK measure, it can be elevated from an IM injection because there's some cells that get damaged when you have the trauma just of a needle. And so that may cause a false reading. That's why people have tended to go with the troponin level as the measure for heart injury. I gave you a page to read in your your pathophysiology book so that you could get a little better written information than your fundamentals text has. So just take a look at that. We don't have to know all of this in depth, but they're important assessments related to cardiac functioning that we need to be aware of. When we're looking at things like the CBC, we're maybe interested in anemia, right? So decrease in red blood cells. What are some things that can cause a decrease in red blood cells? Well, we could have an inadequate supply of iron for synthesis of hemoglobin. So that's going to help give some indication. Number two, maybe there's decreased red blood cells due to bleeding. So hemorrhage, surgeries can all cause a post-op response. A decrease in iron in the diet may lead to anemia. Hemoglobin or red blood cells are not formed because of various diseases. Disorder causing, number 5, disorder causing red blood cells to break down. So there are reasons for anemia. Physicians dig deep into this, but we need to have an awareness of where a client's at and how this information syncs to what we know about the client and their history and their admission diagnoses. Signs and symptoms of anemia: chronic fatigue, it's more than I'm just tired. It's this deep inside fatigue, paleness, pallor, shortness of breath, hypotension. All of those things are important assessments that give us insight into the client. We've done our assessment and we've gathered up everything we can find related to pulmonary and cardiac functioning. So what are some potential nursing diagnoses that could help us? Well, maybe they have ineffective airway clearance or breathing pattern, decreased cardiac output, impaired gas exchange, risks for infection, ineffective tissue perfusion, impaired spontaneous ventilation. All of these are potentials related to circulation and breathing. Just wanted you to know they're there. So as a nurse, we can look at specific interventions that we can do to help support a client in response to whatever their medical diagnosis is. When it comes to planning, a couple ideas of some measurable goals and outcomes. Our client, let's go back here and see, maybe ineffective airway clearance or ineffective breathing patterns. So what could a goal be? Lungs are clear on auscultation throughout hospital stay. Very measurable, because we certainly don't want them to not be clear. Maybe client coughs productively within 24 hours. Because they have depressed breath sounds or pneumonia, they haven't been having a productive cough. Respiratory rate will remain between 12 to 20 throughout hospital stay. Very specific, very measurable related to respiratory function. We want to set our priorities, remembering to keep Maslow's in mind. We're going to look at breathing, circulation, and move from there to deal with psychosocial needs. So these are first line items that we need to deal with related to a client's functioning. So what are some assessments that we can do to support the client's health and promote their health? Well, body weight, and that's not going to get fixed in a day, but helping people associate the importance of good behaviors related to, and we can just kind of go to the next two as well, they kind of all fit together, diet and exercise, because sometimes just losing a little weight makes it easier to breathe. Sometimes because of their conditions, they can't exercise hard, but everybody needs to do something. People weren't meant to just sit around. So looking at that. We want to also be thinking about types of diets that clients are on. Maybe they need to limit their sodium to 2 grams a day, which, by the way, 2 grams of sodium is 1 teaspoon. 1 teaspoon of salt. for a 2-gram sodium diet. Well, that seems like, oh, I never eat that much, but it's in all sorts of other things, the sodium. And so helping people understand their diet and hidden sodium. We just got off of our nutrition unit, and we know those processed foods, oh man, they're loaded with salt. So helping people appreciate that those could be at least cut down in their diets. Exercise. Sometimes it's just mild exercise, but regular mild is better than none. Spacing activities, helping people stay healthy. Looking at, and again, this is kind of maybe related to stress and diet, but looking at alcohol consumption. Alcohol consumption can lead to cardiomyopathy. People drink because they're stressed. People drink because it's part of their diet or their habit. And so really being honest, having honest conversation with people to talk about that and how it could affect them. Staying safe in their work environments. And that could be anything from machinery to staying away from environmental hazards and such. Keeping a smoke-free environment. Maybe someone's not a smoker, but they are in a household where people smoke. So maybe developing practices that can help people smoke outside to help protect those that are indoors. There are a lot of things to help with smoking cessation, because the literature would say that 70% of smokers want to quit. But it's not easy. It's an addiction in many cases. So there's a lot of programs. Assess is one, the 5 A's. Ask the clients. How do you know if you don't ask them, are you interested in quitting? Have you tried to quit? Advise them is number 2. Urge every tobacco user to quit. So we're not supposed to be big advisors, but we really want to help people appreciate the significance of smoking and the harm it can do. Assess a client, assess their practices, assess their lungs, assess their history, but assess where they're at. How many times they've tried to quit. Maybe they've tried a bunch of things and nothing's worked. And so we need a good assessment. Help assist the client with tools, with referrals, with suggestions, anything. Help assist the client, help assist them to get connected to support groups that can be beneficial, and then arrange for follow-up. People need support. If people have support, they do better. The literature, the research has been clear on that. So just sending people out the door and go quit, good luck to you, that's not going to be effective. So we want to look at that. There's also the STAR plan, and using the acronym STAR when people are ready to plan to quit. So set a date to quit. This is it. So that's ST. Tell family, coworkers, and friends. Enlist support when it comes to quitting. A. Anticipate challenges, especially during the first few weeks. It's not that easy. So if people are ready for everything that could possibly derail their habit and their new plan, then sometimes that can be helpful. And R, remove all tobacco products from the environment. It's just got to go out with the trash. So if Monday's trash pickup day, everything's out on Monday, and you start your quitting plan on Tuesday, kind of a thing. Just get rid of everything, and don't hang with the people that are smoking for a while, so they can appreciate what's going on. People need regular physical examinations at least once a year, and then people that have comorbidities more often as the need arises. So helping them get that established. Vaccinations need to be kept current. The flu vaccine. The flu vaccine anymore is recommended for everyone, but in particular 65 and older, the ones with chronic disease, those in contact with those people, and everyone needs to get the flu vaccine. The flu season is typically November through April and peaks January through March. The flu vaccine is only good from year to year, and it's not perfect when it comes to year-to-year vaccinations, because they're making the flu vaccine based on the flu of the year prior. But it's at least going to be pretty close and help people combat the flu each year. It takes 1 to 2 weeks for the antibodies to develop, and the flu vaccine lasts for about 6 months. HIV patients can take a flu shot but may need a booster halfway through the season. It shouldn't be given to people that are actively ill with colds or flu, and then checking allergies. And you guys did your med card, so you're pretty savvy on that flu vaccine. The pneumonia vaccine is recommended for anyone with chronic illnesses, immunosuppressed clients like HIV clients, people in nursing homes that are living in community, and people that are 65 years of age or more, and interestingly, the Indian population, more prone to pneumonia. If the pneumonia vaccine is given before the age of 65, people will need a booster after they're 65 or 5 years after the vaccine. If the pneumonia vaccine was given after 65, they typically don't need a booster. There are 2 pneumonia vaccines that are out right now. They may be almost rid of the one, but we're looking at Prevnar 13, which has 13 types of pneumonia antigens in it, but they have a new one that is PPSV23, which is the pneumococcal polysaccharide vaccine, and it has 23 types of pneumococcal bacteria that it works against. So I don't know about you, but I'm wanting the 23 over the 13. So that's what's out there for your clients, and that can help you know what to recommend. Another vaccine that's important is whooping cough, or the pertussis vaccine. And when it comes to looking at that, the DTaP, which is the diphtheria, tetanus, pertussis combination, DTaP formula is for children 0 to 7, and the Tdap is for people 11 to 64. I don't know who gets in the gap between 8 and 11, but so children is the DTaP, and young or older children, young teens to adult, the Tdap. The tetanus component may need to have a booster if someone has been exposed to the tetanus for, I don't know, some dirty something, they got a cut or puncture or something, if they haven't had it within 5 years. But right now, this Tdap doesn't need a booster once it's been given. Oh, whooping cough. You can talk about that when you do peds, but it's caused by the bacterial Bordetella pertussis. It lasts about 6 weeks, the disease itself, and it doesn't usually happen in kids less than 6 months. Most common in infants and young children, but people of all ages can get it. And so we want to take the vaccines to prevent that from happening. We don't need these things. Vaccines are our protection out there, and we need to diligently and persistently get them, our vaccines, as needed. Other things that we want to do is check for dyspnea and manage people's difficulty breathing through pharmacological methods. We've talked about that. There are antibiotics, bronchodilators, mucolytics, expectorants, antitussives. There's a lot of meds that are out there to help keep an airway clear. Oxygen administration. Just a reminder, oxygen is a medication, and we need a physician's order to give oxygen. But it's helpful, and we need to monitor it and be diligent about that. Physical techniques, positioning, spacing activities, coughing, pulmonary hygiene to contain people's sputum so it's not all over the place. And then psychosocial management, like meditation, control of breathing. It can make people really anxious, right? If you can't get your breath. So how do you help people get control over their own oxygenation? It is important. So knowing good positions for breathing, and then support for people that struggle with breathing. I took this picture in because one, just thought it was a great concept map to give you some ideas of how you might study some of this material. And in this situation, we've talked about hypoxia. That was in part 1. So this is how a concept map might look. And so over here, some ideas. How could we maintain good pulmonary hygiene with oxygen expectorants, ambulation fluids? Do you see how they landed all here? These are nursing interventions. And what assessments might we make to help people? Assessments versus implementations. And so a good list of here's a definition for hypoxia. Some more assessments. Who's at risk? What are some complications of hypoxia? What are some diagnoses that are out there? Clinical manifestations, those early signs versus those late signs that we looked at. So just an idea of ways to engage with the material a little bit. I like this. So you might just sit down for, I don't know, a few minutes during your study time and try to explain this to a phone buddy while we're involved in this shelter at home scenario. Some other things that we would do in acute care to maintain airways is mobilize secretions. So how do we mobilize secretions? Well, people need to be hydrated. And they need 2 to 3 liters a day. That's going to help keep those secretions thinner and easier to move. Maybe they need the air humidified, teaching them how to cough. Maybe they need CPT. What is CPT? I know, you wanted to ask me. Chest physiotherapy. When we talk about chest physiotherapy, we're talking about postural drainage, where the head is lower than the chest or the lungs. It could also be where you change someone's position so that the lung can drain. All right, I know, can't see me very well here, but what do I mean? Let's say someone had some right lung pneumonia. What position might we put that client in to drain? So postural drainage, to get the secretions to move. Well, you want to put the good lung down and the affected lung up so that the secretions will drain down. It's like, why do I want the secretions into the other lung? Because the other lung's not affected right now and it can be mobilized out. We got to move it out. Have you ever just had the worst stuffy nose head, and it's like you lay on your side and it's like, oh, it clears out those sinuses and you can finally breathe on your left side, or your right side, whatever's up, and then, oh, you just got to move. You've been on that side too long and you turn over and everything starts draining, and then you can't breathe out of either side, and then finally it all shifts and goes to the other side. That's what we mean by postural drainage. Percussion, when it's somebody's lung, is where we could cup our hands. Oh, got my notebook in my lap. We could cup our hands like this and pound on somebody's lung area. It's percussion. Or respiratory therapists have these kind of cups. You know what they look like was when we did our CPR and you had to put that rubbery type mask around their face. Well, instead of it being a breathing mask, it's just a round like cup with those soft borders, and you go use that to percuss. We're not slapping on them with flat hands because that can hurt them. You don't want your rings or hitting. It's actually the puffing of air that's created in the cupped area that causes percussion and helps loosen secretions. Vibration, so a vibrator on the chest that can help loosen secretions. Yeah, are things that we can do. So I wanted you to be familiar with that. When we're doing postural drainage and even the percussion and the vibration, you want to do it before a meal, right? You don't want to have their head low or where they could have some regurgitation. could cause vomiting, and that's going to lead to aspiration. They got enough trouble without us doing that. So make sure that it's done before meals and bedtime. And usually when they're in a position that we're trying to drain them from one side to the other, it's usually for about 10 to 15 minutes. Stay with your clients when you're doing that because you just don't know if they're going to cough up something and then they can't breathe. Clients that have cystic fibrosis produce tons of sputum, and they usually do, and what they mean by that is more than 30 milliliters a day. That's a lot of sputum if people are just coughing that up. And so they'll do the postural drainage and percussion multiple times during the day to help mobilize those secretions. Postural drainage, especially when we're putting a bed, for example, in Trendelenburg's, my fingernails are the head down, Trendelenburg to help drain. Not everyone can do that, right? So people that have head injuries or bleeding disorders, high blood pressure, they're already short of breath. Can you imagine putting a COPDer in Trendelenburg to help with drainage? No. Contraindicated. They are already orthopnic. So it doesn't make sense. People that have osteoporosis or fractured ribs, we're not going to do percussion on them, right? Or turn them upside down. It's too much pressure already in their thoracic cavity. So just know that those things exist. Suctioning. We practice suctioning in the skills lab, but I just want to give you some background about suctioning. Remember when we suction that we need to oxygenate before and after suctioning to help prevent oxygen depletion. That suction catheter is just suctioning. It doesn't know what's going on in there, so it's going to suction oxygen as well as hopefully the sputum that's got people plugged up. So make sure that we're giving good oxygenation. We need to let people recover between suctions, and so give them at least a minute. And again, it depends on who you read. They say 1 to 2 minutes, but make sure they're recovered. We got that pulse oximetry on. Watch it and see how they're looking. Remember, this is important. Tracheal suctioning is sterile. It's a sterile technique, and it cannot be delegated. Here's the other thing that I want to make sure we understand. Suctioning is determined by physical assessment. So you don't just suction every 4 hours or every 2 hours. They may not need it. And if they need it every 30 minutes, then you better do it, right? So it's determined by the assessments that we make. Nasal suctioning is preferred over oral because think about someone just sticking a tube in the back of your throat. So there's less gagging involved if we go nasally and go on down. So that can be helpful. Orotracheal and nasotracheal are used when people can't manage secretions or cough. And so that's important for us. The best indicator of positive results from suctioning. What do you think? They needed suctioning. They weren't able to mobilize secretions. They were drooling. Their SpO2 had dropped. There was indication that they needed to be suctioned. What's going to let you know that suctioning was successful, positive? Say it out loud. I can hear you talking out there. All right, lung sounds are clear or clearer. That's something, right? The SpO2 increased. Their color pinked up. Any of those could be helpful, right? So you got some results out there. Okay, artificial airways, they're talking about the tracheal, which I put the trachea here, tracheostomy that people would have. Maybe they dropped an airway in and they're on a ventilator. So any of those are considered artificial airways, of which you'll work with in second semester. People have to breathe, number one on Maslow's, and so our job is to facilitate that. Things that we can do to promote lung expansion is positioning. Already talked about that. It's much easier to breathe in high Fowlers because the diaphragm drops, and so it's easier to expand the lungs. So positioning, that's why people have that sit in that orthopnic position, because that helps them get air into their lungs. So positioning is important. This is fascinating to me, and I want to just emphasize here when it comes to positioning, turning a client, just turning them from side to side or repositioning, increases both circulation and respiratory function. You get two things out of one, got more bang for your buck. Frequent position changes is the simplest and most cost-effective method of promoting circulation and respiratory function. Right? Position. Great. Incentive spirometer is used to maximize lung expansion, alveolar filling, and decrease atelectasis. So the key to that is we want people to take slow, deep breaths in. Inspirometer, incentive inspirometer, right? That's why I did inspire in yellow there for you. Pursed lip breathing. Why do we use pursed lip breathing? You got to take notes here. I have 1, 2, 3, 5 things. I skipped 4, I know. Okay, why pursed lip breathing? We know what pursed lip breathing is. Look like you were blowing out a candle or squinching those lips up. It does these things. It's going to increase 2 things. Yeah, increase 2 things, decrease 3 things. Are you ready? Let's do our 2 increases. It's going to increase expiration. Make sense? We want to prolong expiration for the client. It will increase patient control of dyspnea. This is a good thing, right? Increased expiration, increased control. It will also decrease air trapping. It helps move all the air out so it doesn't get trapped. It decreases alveolar collapse. We don't want to have atelectasis, right? Because then we have decreased oxygen exchange. So we want to decrease alveolar collapse. And it helps decrease airway narrowing and resistance. All right, 5 things. Very important. Here's a new one for you. Sighing. Sighing. This would be a good time to just give a good sigh. I'm almost done. Seriously, we've only just got to talk about oxygenation. We're going to make it. But a good deep sigh of relief. And that sigh stretches the alveoli and produces surfactant, which in turn promotes lung expansion and prevents alveolar collapse. We just helped our lungs today by just having a good old sigh. All right, so one more time. Sighing stretches alveoli and produces surfactant, which in turn promotes lung expansion and prevents alveolar collapse. Medications, we've talked about them. Medications can be very helpful in facilitating lung expansion. All right, let's talk a little bit about oxygenation. Why oxygenate? Because we need oxygen, and so oxygen therapy may be the support that the client needs. To appreciate oxygen therapy, we've got to understand some language around oxygen therapy. First off, there's this value that gets talked about all the time, which is the FiO2. The FiO2. That stands for the fraction of inspired oxygen. FiO2, fraction of inspired oxygen. This really is very simple, but it gets utilized and your brain might just have to shift gears on it when there's a couple of ways of saying the same thing. But the language of FiO2 means this. Normal room air contains, remember we talked about this, what's the percentage of O2? Right. 21%. I knew you knew it. So 21% oxygen is in our air that we breathe, where 78% of our oxygen is nitrogen, and then there's 1% of trace elements and carbon dioxide and such in the air. All right. When we talk about FiO2, we're breathing in, you and I that are just sitting here breathing the air are breathing in 21% O2. That's our FiO2. But the FiO2 gets expressed in a decimal. So often you'll see, oh, their FiO2 is 0.21, which means they're breathing room air. All right? It's not as hard as it sounds. It's very simple. FiO2, the fraction of inspired oxygen. We're only getting 21% out of 100% of available air. Only 21% of it is our oxygen concentration. Here's where oxygen therapy can be so helpful, and that is in oxygen therapy, we can increase the FiO2 or the percentage of oxygen that they're getting above what's available in room air. Make sense? Yes, I knew you'd get it. So here's some things we need to remember. When people are getting high concentrations of oxygen, and especially higher than room air, we need to remember that oxygen is highly combustible. However, it doesn't just spontaneously burn, like it'll be sitting there and they've got an oxygen tank and it could just blow. No. What it means is that it can fuel a spark or ignite a fire. It can fuel fire. And so we need to be careful that people aren't around sparks or flames or electrical equipment that could potentially cause fire. And so that's what's really key. No smoking, avoiding open flames, avoiding synthetic clothing, because synthetic clothing can build up static electricity. That's the key. It's not that, oh no, our clothes are all going to burn up. It's because of the potential for sparks, right? We've seen them on our hair and stuff. We can make that happen with a balloon or whatever. We need to have that client avoid oils. So let's say their nose is getting dry. Oh, I know I'm touching my face, but I haven't been around any coronavirus today that I'm aware of. I've been home. Shelter in here. They shouldn't put Vaseline on their nostrils if they've been dry. They need to use a water-soluble type lubricant that doesn't have the potential for being combustible. Oxygen's prescribed for hypoxemia, loss of lung tissue due to tumors or surgery, severe anemia or blood loss, inadequate RBCs or hemoglobin, increased metabolism, fever. People have a temperature and so they may need oxygen. Oxygen is supplied through a variety of methods, and your book goes through a few, and so I'll just mention a few of them. But I want you to understand, I think that's most helpful for us is how oxygen is effective. All right, so we know that oxygen can be delivered through nasal prongs or nasal cannula, right? The two little prongs that go up into the nose. All right, we know that it can be administered via a mask, a simple mask, a non-rebreather mask with a bag or without, and then through Venturi methods and such. And believe me, there are even more methods beyond that. But let's look at why one might be chosen over the other. Now, know for sure with me that when oxygen is delivered, oxygen that comes from an oxygen delivery system or tank is 100% oxygen. However, when that oxygen mixes with room air, the client doesn't always get 100%. That's what's key. So someone that has nasal prongs is actually getting oxygen from a low flow device. If we set the oxygen at 1 liter or 2 or such, with each liter of oxygen, it increases the FiO2, are you with me? By 3 to 4%. And it starts like this. Let's just talk about nasal prongs, nasal cannula, what we're most familiar with. If someone has nasal prongs in and the doctor prescribes 1 liter of oxygen, then the FiO2, or the concentration of oxygen now, goes up to 24% with 1 liter. Why? Why not 100%? Because it's mixing with room air. The client's breathing in air from the room around those nasal prongs through their mouth. It's mixed, and so it's a small increase of oxygen concentration. Now it starts going up by 4% for every liter. So 2 liters would deliver 28%. And when people talk in FiO2s, they'll say 0.28, right? Same thing. Don't worry about that. Same things. 28% oxygen concentration. The fraction of the air they're breathing, that's oxygen. 28%. If they increase the liter flow to 3, it goes to 32%, 4, 36%, 5, 40%, 6, 44%. Most of the time, we deliver below 4% because that liter flow gets so high and hard to breathe with that's very drying and irritating to the nostrils. So we don't go above 6 liters, and right now, the practice is that with 4 liters or more of oxygen, the air needs to be humidified. It used to be that at 2 liters, more than 2 liters, we would humidify the oxygen just so that the nostrils wouldn't be so dried out there. All right, the face mask, the simple old face mask, can deliver the highest concentration of oxygen. And for face masks to be accurate, that's the picture that we've got going here on the PowerPoint slide. For a face mask to be accurate, it has to fit snugly to the mouth. It has to be secure to deliver an accurate amount. Face masks get set at 6 to 10, well, they can be set up to 15, but 6 to 10 liters in a face mask, simple face mask, will deliver 35 to 60% O2. I don't know if you can see well on this picture, but there's little holes on the side, so there's still a little mixing of room air with the simple face mask. Sometimes there's a big hole, kind of like that, on each side. So there's mixing that occurs. If someone needs to get 100% O2, they need to have a liter flow of 10 to 15 liters to get anywhere from 60 to 100%. But with the simple face mask, that's how you're going to get 100%. A face mask should never be used with a liter flow less than 5. You have to have enough flow going in that mask to force out the CO2 that is exhaled. You don't want people rebreathing that. They need the oxygen. So it helps clear and flush out that mask. The non-rebreather mask we talked about a little bit in the skills lab are masks that have valves. Well, there's a partial rebreather and a non-rebreather. The partial rebreather mask has the bag that comes down at the bottom of the face mask, and that helps be a reservoir for more oxygen. It's still considered a low flow device, and the partial rebreather mask can deliver 40% to 70% oxygen at flow rates of 6 to 10. So you can get a pretty decent concentration with that liter flow. The non-rebreather mask has a little valve, a little flap over those holes so that the CO2 can get out and less room air gets in with these one-way valves, so you're getting more oxygen. There's only a valve on one side, so there's still a little bit of mixing over the holes that are on this side, so some air will get in. But now you can get a higher concentration of 60 to 80% O2 with a 10 liter flow. And then just for your information, your need to know, and that is a Venturi mask, which has little attachments that set the flow rate as far as how much oxygen mixes with room air, is the most accurate administration of oxygen. So the Venturi mask doesn't deliver as high of concentration as the simple or the face mask, the non-rebreather, but it delivers the most accurate concentrations, most consistent. And so hopefully you got a chance to look at those masks that have the valve. So Venturi masks for those. All right, look at your book, look at some pictures, and just kind of get that in your head, what you're doing. Can I just mention that when it comes to patient care, if people need oxygen while they're sitting around and resting to maintain their SpO2s, they need it when they're active, like when they're walking to the bathroom, if they're walking in the halls. So they need to have some kind of portable method of keeping their oxygen going, or long cords that they can take with them when they walk to the bathroom or get up to bedside commodes. Don't let them just take off their mask and then walk. That just defeats the whole point here of oxygen. Second, how do you eat with a mask on? Well, remember, this is ordered. This is a physician order. It's a medication. So if people are they have to eat. Most people, if they're comatose, that's another subject, but people that need to eat can't eat with the mask on. It's too hard. And so you need to have a supplemental flow rate for nasal prongs for eating, for activity related to that. People don't like the masks very long. Can you imagine how claustrophobic? You can get skin breakdown around the edges. They get sweaty and they're kind of miserable for long term. So masks are usually used for the short term to get people stable, and then they try to get them onto some other kind of nasal delivery system. Home oxygen therapy is delivered through a variety of means. They can have compressed air, which is a machine that actually takes air from the room. They're kind of noisy, and compresses the air to get higher concentration, as opposed to delivering the canisters like you see in the picture there that are 100% oxygen and then have to be refilled regularly. So the compressed air is a little cheaper and is ordered specific to whatever the client's needs are related to home care. But they need to be able to monitor themselves and know what a hypoxia feels like, and have some kind of SpO2 monitor at home as well. Oh, here's some delivery systems to talk about. There's our simple face mask. See the little holes? So that's how they're getting some mix. The partial non-rebreather should have a few little holes in here. It's an older picture, but I just like that it was a picture here, and that gives a pretty good concentration. The non-rebreather, can you see the little valve right there? And so it's very soft little flap, so that when people exhale, the CO2 comes out, and when they inhale, the flap goes down, so it's not getting so much mix of air. And then the Venturi mask, you can see the little valve. What I like here about this next picture is this is a nasal prong type of cannula, but it has now a reservoir. This is a nasal reservoir or a mustache style reservoir, and that cannula can actually increase the FiO2 by 0.5%. So hey, you get a little bit more concentration without having to have maybe the nuisance of a mask. Okay, so in the green background picture, you can see another a picture of that type of mask, and then you see this other one, and that's a pendant. So the nasal prongs are right here, if you can see the little prongs, but this pendant is like a reservoir that can actually hold on to oxygen as well, to help increase that FiO2 by a little bit as compared to the plain nasal prong. So there's a lot of devices out there to facilitate oxygen delivery to get the best outcome for the client. Okay, so some other things that we can do to help maintain and promote cardiac functioning, and that is promote rest. One of the easiest things that we can do for people that are struggling with breathing and cardiac functioning is to teach them to space their activities, to not do everything all at once and then rest the rest of the day, but to get up and do a little and stretch and rest, and then eat breakfast and rest, and then an hour later to brush their teeth and maybe wash their face, and then in an hour or two then take a walk, and not just do everything at once. Remember positioning, elevate that head of the bed. It should be our number one action, implementation to help with breathing. Avoid the Valsalva maneuver, which is that bearing down, that grunting, straining to have a bowel movement. Maybe clients need some kind of stool softener or a stimulant to help them with bowel movements. Fluid balance. People that get edema struggle, as well as people that aren't getting enough fluids. So looking at fluid balance, which will be our focus here in a few weeks, but fluid balance. And then medications, which can help clients. Inotropics, they strengthen the heartbeat. Antidysrhythmics help regulate the heartbeat, as well as antihypertensive, just as some examples of meds that can help promote cardiac functioning. TEDs, or anti-embolic stockings, AES, or sequential compression devices on the legs. They need to be removed every shift for at least 20 minutes. Get a good look at their legs and see what's going on. Make sure they're not getting pressure sores on them. Once people are up and walking, they're not really that critical, but when they're in bed, they can be helpful. So what we have a picture of here is sequential compression devices. They're wrapped snugly on the client, and then they're connected to a machine. The machine alternates filling those. It's like putting an air mattress kind of around your leg. It fills up with air, rotates back and forth, and the pressure that's in those is preset to be about 40 millimeters mercury pressure. So compare that to your blood pressure cuff when you're putting just a little bit of pressure in. You can delegate the application of the TEDs or the SCDs to nurses' aides. And you need to assess the legs when they come off, but aides can put them on and take them off to assist with care. Elevating legs can help increase the return blood flow, so that can be helpful. When blood flow needs to be increased back to the heart, then the legs need to be elevated above the heart. So making sure that they're positioned appropriately. People that have cardiac compromise, venous stasis wounds and such, they should have no pillows under their knees or knees bent greater than 15 degrees. And think about this. Okay, I kept their legs straight, but I have their head elevated. That's a too severe of a bend, even at the waist. So we want to increase the blood flow, not constrict it. DVTs are associated with the development of about 90% of all pulmonary emboli and is one of the most common preventable causes of hospital-related deaths, especially in older adults. So we need to really be attentive to that. One of the things we can do to help prevent DVT is leg exercises. And so leg exercises, the easiest, maybe best one that we can do is simply dorsiflexion and plantar flexion of the leg, up and down of that, not leg, but foot, to help increase the circulation, the tension of the muscle there, to help promote blood flow. Yeah, all right. And I told you we were getting there. So here's a couple questions to wrap this up, and here we go. The nurse is caring for a client who is admitted with an exacerbation of COPD. The client's respirations are 28 with dyspnea on exertion. The client is receiving 2 liters of oxygen per nasal cannula. What's the FiO2? 28. Okay. The morning SpO2 is 92%. Well, I know normal is 95 to 100, so they're low. Which nursing intervention is of priority? I don't know. Let's see what they have to offer. So we're going to pick the best of what we've got. Are we just going to monitor the client? I think there's something we should be able to do. Should we notify the physician? Possibly. Get an order to increase the oxygen? Well, we'd have to notify the physician. Place the client in semi-Fowlers. I don't like that. I want them in high Fowlers. So I don't even like 3 of the 4. So there's nothing that they're offering me here that would be helpful. What other choice do we have? Oh, I don't like that.